Distinguished speakers, members of parliament from Ghana and across Africa. It is a privilege to address this assembly on the topic of negotiating health sovereignty in global policy. As reflected in Article 7 of the draft African Charter, health sovereignty can be defined as the personal and national independence to define and apply the right to health. Since the COVID-19 pandemic in particular, maintaining this independence has grown more challenging as calls for an internationally centralized approach to interpreting and applying the right to health have become increasingly prominent. Two specific areas of health sovereignty warrant closer attention. First, soft law approaches to the content of the right to health have gained significant ground and are increasingly being presented as binding interpretations. Hard law, the law in the binding international conventions related to the right to health, are increasingly being ignored. On the issue of abortion, for example, both the WHO and various international human rights mechanisms have intensified their calls for universal access to sexual and reproductive health and rights without any limitations or gestational age limits. Second, the proposed pandemic agreement seeks to consolidate a centralized approach to addressing global health emergencies, one that risks overlooking the geographical, cultural, and religious dimensions that shape how the right to health is applied at the national level. When comparing the current Africa Group's negotiation priorities in the Pathogen Access and Benefit Sharing Annex to the Pandemic Agreement at the WHO, with the draft charter, three principles emerged that could strengthen health sovereignty in the outcome documents. The first is the principle of subsidiarity. Decisions must be made at the lowest appropriate level to ensure accountability and a right to health that aligns with each sovereign state's constitutional framework. This can be achieved by clearly defining the mandate of international health institutions as focused on providing guidance, support, and data, rather than setting normative standards. Time-bound interventions can further reinforce national health sovereignty. The second is the need for a renewed commitment to local capacity building. The success of the WHO, including its regional agencies, should not be measured by its growth as a centralized agency, but by its progressive redundancy as national capacities mature, including in the context of public health emergencies. Negotiating proportionate emergency policies requires accounting for the foundational determinants of health, such as hygiene, nutrition, and high-burden diseases. Only by doing so can we ensure that resources are not diverted towards expensive technological interventions at the expense of the broader health of African populations. The third is the continued integration of ethical principles in defining the right to health. Human dignity as the foundation of human rights must serve as a moral compass in determining the scope of the right to health. Strict conflict of interest rules are an important mechanism to uphold this standard. In summary, negotiating toward health sovereignty will advance an accountable and equitable right to health, one that fulfills the positive obligations that many respected constitutions have entrusted to their mandate holders. The shared flyer from the International Health Reform Project, an initiative developed in collaboration with African academics, provides an overview of key recommendations and pathways to national actions. Past successes or institutional dependencies should never become barriers to a critical and honest assessment of the legal or factual realities surrounding international health organizations' approaches. I will close with the words that the distinguished former president of Liberia, Her Excellency Ms. Ellen Johnson Sirleaf, spoke last year in Accra during the Africa Health Sovereignty Summit. Africa's health future will not be given it must be claimed. Thank you very much.
Merci beaucoup. Vous avez la parole.
Yes, I will shortly answer also the question what we can learn from external finances for vaccines. I think it's very important to uphold a factual approach towards the extent of pandemics. The WHO is an organization that is largely financed by private organizations, private entities, and pharmaceutical companies. And how pharmaceutical companies look to pandemics and pandemic prevention, preparedness or response is different than the situation on the ground. When we look to estimations of the G20 and the WHO itself, the pandemic prevention, preparedness and response mechanism will cost over $31.1 billion annually. We all know that the monetary assessments for addressing nutrition support, malaria and tuberculosis is going significantly down, mainly because money is allocated to pandemic prevention, preparedness and response. All that should be avoided, but the current outbreak of Ebola caused 223 deaths at this moment for May 27th, according to the WHO. That is the same number of deaths that happen in 3 days for people with tuberculosis or malaria. Why are these diseases being so under-financed? Well, the reason is they want money to uphold the system. Thank you.
Nous remettons la parole.